So today I am so excited to be able to present physician and a patient with narcolepsy perspectives on managing the disruption of narcolepsy. So I'm Dr. Anne-Marie Morse. I'm the Director of Child Neurology and Pediatric Sleep Medicine at Genoa Children's Hospital at Geisinger Medical Center in Danville, Pennsylvania. I am being a paid consultant and speaker for Avadel for this presentation today, and I am completely so privileged to have the opportunity to also present today alongside Diana Anderson, who also is in medicine, but is an individual who also has narcolepsy. Diana, would you like to give yourself a presentation as well?
Hi, yes, good afternoon. Thank you, Dr. Morse. My name is Diana Anderson, and I am actually a physician assistant, and I have been diagnosed with narcolepsy type 2. I was diagnosed when I was 34 after experiencing symptoms for about 10 years. So I'm very happy to be here, and I'm looking forward to this.
Awesome. So I am really excited to have this conversation today and thrilled with what a great attendance that this conference has been seen, and so excited that I had the opportunity to even be invited to participate. So topics of discussion today are going to include, number one, the importance of the sleep-wake cycle. What is narcolepsy and its symptoms? And so I might be preaching to the choir a bit in regards to this, but sometimes I find that when we're discussing the symptoms, patients are able to identify new things that maybe they hadn't previously recognized in themselves. We're going to take a good deep dive into the disruption of life. I think that this is one that very much I take to heart when I'm talking to my patients in regards to what are their symptoms. You're much more than an Epworth sleepiness scale. You are an individual who has real life things that are going on, and you're feeling disrupted in regards to being able to achieve all those. We want to be able to really identify, how do we manage this disruption, combining lifestyle changes alongside regular pharmaceutical treatments. And I want to really spend some time to be able to help empower patients in their journey, to be able to better advocate for your care and really engage in that shared decision making. Very frequently when I'm speaking about narcolepsy, I commonly will say that I want my patients to be the captain of the ship, and I only want to be the first mate. I want to present all of the information and the strategies that we can utilize, and then we together need to work and understand what strategies are right for you. And I'm hoping that today people walk away from this conference with a lot of these new tips and tricks that are only going to lead to more optimal performance for themselves and life experience. And we'll finally close with some Q&A. As has been mentioned, I love an interactive conference. I hate when I'm attending conferences and I just feel like I'm being talked at. So if you have questions, please put them in the Q&A. I'd love to see what your questions are and try to address them as we're going through. So when we're talking about sleep, just in general, a natural restorative sleep-wake cycle is fundamental to good physical and mental health. It is a necessary component to feeling recharged and feeling well. The sleep-wake cycle refers to that pattern of time we spend awake and asleep every 24 hours. It's an important role in that sleep-wake cycle to consolidate during the night so that you're able to stay awake during the day. So again, this restorative sleep can impact people in terms of the way that they feel, the way they perform, and then overall, just their overall quality of life. Narcolepsy, however, is a chronic, lifelong neurologic disorder that is characterized by a disrupted sleep-wake cycle. I very frequently will describe that in individuals who have narcolepsy, sleep fragmentation is really a hallmark of the features that they experience. They have sleepiness intruding during the day, and unfortunately, they have wakefulness intruding during the night. And therefore, the lines between awake and sleep become completely blurred, and they're never really experiencing any true restoration. No matter how much sleep a person with narcolepsy gets, they frequently are feeling as though that they're never re-energized and able to take on what the day has to throw at them. And so this becomes a really critical component that sometimes we're not discussing as well as we should. We measure you with an Epworth and we ask about how many cataplexies you have, but we're not really asking all of the detailed questions that perhaps we should in order to understand how that disturbed nocturnal sleep may be negatively affecting you and what strategies may even be helpful in being able to produce a better day-to-day function. When you're talking about the normal sleep-wake cycle, this is what typically should be seen, is that an individual is able to fall asleep. They quickly cycle through some of those lighter stages of sleep, such as stage 1, stage 2. In the beginning of the night, they spend a lot of time in that restorative stage of sleep, that slow wave sleep. That's that stage of sleep that it's like waking the dead when someone's in it. They're generally maybe dreaming during that stage, but it's the kind of dream you're unable to recall. As the night progresses in someone who has normal, healthy sleep, we see that stage of non-REM 3 sleep become less and less throughout the night. And then we see this normal progression of REM, where there's a short duration of REM in the beginning of the night. And as the night progresses, we're spending more time in REM sleep. Unfortunately, an individual who has narcolepsy, they're unable to achieve this cycle of sleep. And most frequently, if you were to look at the same type of picture, which is called a hypnogram, what we're seeing is significant sleep fragmentation, where there's wake intruding, short segments and long segments of REM sleep all throughout the night. And it's compromising that ability to achieve that slow wave sleep and that restorative stage of sleep that is contributing to so many functions that allow us to maintain our wellness. So when you're talking about narcolepsy, those PET-TAB symptoms that we very frequently are referring to are excessive daytime sleepiness, the most sensitive symptom in narcolepsy, meaning 100% of individuals with narcolepsy experience this. It's important to note that excessive daytime sleepiness may have many different faces, everything from what commonly gets described as the individual having difficulty staying awake and really dragging, or even potentially falling asleep inappropriately in sedentary activities. However, we recognize that some people may experience excessive daytime sleepiness differently. They may not describe that they are having this inability to stay awake. They may describe moodiness, irritability, inattention. In our younger kiddos, we may even see hyperactivity as a compensatory mechanism. I know if I'm little Johnny and I'm feeling sleepy, if I keep moving around and staying on my feet, getting out of my seat, walking out of classroom, talking to the kid next to me, maybe even looking like an ADHD, that I'm not going to fall asleep. And sometimes these strategies aren't necessarily purposeful. They're just kind of compensatory. Cataplexy is one of the most specific symptoms, meaning if I elicit a history of cataplexy, it's narcolepsy until proven otherwise. We'll talk a little bit more about cataplexy in a few slides. Sleep-related hallucinations and sleep paralysis don't uncommonly occur together. So sleep paralysis are episodes where we're experiencing REM atonia. I can't move, but my brain is awake. I'm fully aware of it. I feel frozen or stuck. And it's not uncommon that these sleep-related hallucinations, where a person is transitioning between sleep and wake and feeling as though they're seeing, hearing, feeling things that aren't really there. These things can occur together and sometimes yield an extremely frightening experience. And the final piece is that sleep fragmentation. And most specifically, people do describe disturbed nocturnal sleep. But I think it is important to capture the fact that individuals with narcolepsy are having fragmented sleep across 24 hours. They're most visibly being seen by that sleep intruding during wakefulness, but the disturbance of their nocturnal sleep is one that shouldn't be ignored, and many times is maybe just as frustrating as that inability to stay awake during the day. So as I mentioned, excessive daytime sleepiness is the most frequent complaint. It usually is the reason that they're coming to the attention of their medical provider. Excessive daytime sleepiness can be present in a variety of different conditions, so it does take some scrutiny to identify if that is due to narcolepsy or central disorder of hypersomnolence or for some other reason. Persistent sleepiness and often a general lack of energy, even after prolonged nocturnal sleep, is generally one of the key characteristics that we may see. And because of the fact that it can be present due to other things, it sometimes can lead to another diagnosis. It's important to recognize that in individuals who have narcolepsy, they also are at risk for other disorders that potentially can lead to excessive daytime sleepiness. In fact, patients with narcolepsy are 18 times the likelihood of having comorbid obstructive sleep apnea. So unfortunately, if you have that polysomnography first that demonstrates sleep apnea, sometimes people end up seeing that delay in diagnosis of narcolepsy because the physician and the patient may falsely believe that they've achieved the right diagnosis. Sleep fragmentation, as we mentioned, are these frequent arousals that can lead to reduced efficiency, but it's also that sleep intrusion. When we're talking about narcolepsy and the causative pathway of narcolepsy, many times we are referring to the lack of a neurotransmitter called orexin or hypocretin that generally is playing a role of stability in our sleep-wake cycles. We recognize in narcolepsy type 1, there is an absolute reduction or sometimes even absence of this neurotransmitter. The exact mechanism of what's going on in narcolepsy type 2, we're not as quite of aware, but we do still believe that that likely is playing a significant role. And so what this results in, and I love the fact that this picture is a seesaw, because this is how I describe it to my patients, is that when the brain wants to be awake, that seesaw should be kind of fully dedicated to staying awake. And as the day progresses, the brain should kind of shut off those signals to say, you should be able to go to sleep. And unfortunately, what happens in an individual with narcolepsy is that they're lacking that neurotransmitter that's stabilizing the fulcrum or stabilizing that seesaw. And instead of having these smooth transitions, they're having flipping and flopping throughout the day. And they're not only flipping and flopping between wake and sleep, they're specifically flipping and flopping between REM sleep and wakefulness, which explains the whole gamut of symptoms that the individual is experiencing. And sometimes when I am able to describe that to a family of that, that's why they're experiencing all of these unusual symptoms. When I'm talking about excessive daytime sleepiness and cataplexy, sleep paralysis, sleep-related hallucinations, fragmentation of sleep, it sounds as though I'm making up a disease. I've just pulled a bunch of things together and threw it in a hat. But I'm able to explain that it all is based on the same foundation of REM, dissociation, and fragmentation of sleep. It becomes so much more clear and helps us to also gain some ideas of how to move forward. Narcolepsy is a tremendous disruption to life, both day and night. The impact of narcolepsy is felt professionally as well as personally. It can interfere with social and personal interactions as well as work performance. It's important to me when I see individuals with narcolepsy that I ask them, where is it that you feel as though that you can't do what other people can? And many times that is resulting in them describing to me that I'm unable to get to work on time. I'm at risk of losing my job because I've had so many days being absent or tardy, or I just lose that focus and I need this to take that nap during the day. Within hours of waking, people with narcolepsy can just feel as sleepy as a healthy person would if they were up all night. And that puts them at an unfair disadvantage. This disruption, as mentioned earlier, extends beyond normal daytime hours, and it also affects the nighttime sleep. So I really want to go over some really important narcolepsy impact questions with you, Diana, because I know that we've had the privilege of being able to speak before, and I think you have such an incredible journey. And the fact that you're also in medicine, it kind of gives you this other dynamic that you sometimes can reflect on. And I really would love to have you share what your journey to diagnosis was like.
Sure. Thank you, Dr. Morse. So I started having symptoms in PA school, actually. So I started going to PA school when I was 24, and I would notice that it was like having a full-time job. It was like going to class 8 to 5 Monday through Friday, and then you were studying on nights and weekends. When I would have breaks during the day from class, whether it was during lunch or maybe we had an extra hour in between courses, I found myself going home and taking a nap during that time. If I didn't, then I would find that I was very tired in the afternoon and I would fall asleep in class. And, my best friend would have to nudge me on the shoulder and say, hey, Diana, wake up. This stuff's on the final. Why are you sleeping? You just had a nap. And I didn't really think anything of it at the time. I just kind of chalked it up to being in PA school, and like taking in all that information was exhausting. And everybody said it was going to be hard. So I was just like, well, it's hard. So, fast forward a couple of years, I did graduate. I did pass my boards and became a PA. Started practicing, and I met my best friend at a conference in Buffalo about a year after graduation, and we were supposed to go out one night and have a really good time and grab dinner and some cocktails and be out on the town as like a reunion. And, when 9:30, 10 o'clock hit, I looked at her and I said, I got to go home. Like, I can't be out. I'm going to fall asleep standing up. I can't stay up late. Whereas, prior to PA school, I had no problem staying out, and, in undergrad college, I didn't need naps. But this night, it was to the point where it was 9:30 and I couldn't keep my eyes open at the restaurant dinner table. And so my friend, she looked at me and she said, Diana, this isn't normal. And I said, well, we're just tired. We had a long flight. And she's like, no, 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 you're tired. She's like, this is not normal for you. This is not how you weren't like this prior, to starting school. And I really think you need to get this looked at. And I just I said, she's in the medical field just like me because we were in the same program. So maybe I should take her advice. And so I did. So I went to see a sleep specialist. But I want to note also that prior to this, anytime I would tell someone that I was tired, it was, well, you're seeking a hard profession and you're studying a lot and having a job and everybody's tired. So prior to this moment, I just assumed that I was tired like everybody else. I just maybe couldn't handle it quite as well. So I went and made an appointment with a sleep specialist and explained my symptoms. They did an evaluation, did a physical exam, and determined that it was warranted for me to undergo a polysomnography or a nighttime sleep study, followed by a daytime sleep study to assess my sleep patterns and if I was having, true hypersomnia. So once I went through that sleep study at night, and they determined that I did not have any sleep apnea or anything like that at that time. It was immediately followed by the daytime sleep study, which included a series of 5 naps. And I was able to fall asleep within 2 minutes for every nap. And so when I went back for my follow up to go over my results, the sleep specialist said, well, you have narcolepsy. And when they told me that, I kind of just sat puzzled. I knew what it was. I learned about it in school, but I'd never met anybody with narcolepsy. I also just kind of assumed that, well, okay, I have a diagnosis as to why I'm so tired, so it could probably just be fixed. I could just probably take a medicine and I could feel, that normal feeling. And when I realized that, started reading up on it more, I realized, well, this is a chronic condition and this is something that's not going to go away. That was a very big realization for me. And I remember looking the doctor in the eye and saying, well, wait a minute. So everything I've been feeling over the past 10 years is not normal, but what everybody else is feeling is normal. Well, I want to know what that normal feels like. I want to know what it feels like to not have narcolepsy. And so that was really almost a kind of disappointing moment in history for me. I did receive the diagnosis. It was good to know that I did have something going on, but also knowing that it was a chronic condition. It was something that I was going to basically have to live with for the rest of my life because there's no cure. That was kind of disheartening for me. So that's my journey.
So if you were to describe after you got diagnosed, and I think you even highlighted of what is it like to not have narcolepsy, because it almost becomes kind of a fantasy or a distant reality for many people. What would you say managing narcolepsy and having the symptoms of narcolepsy, how has it impacted your life?
Despite me trying to initially kind of fight it and act like I could still feel like everybody else, it has significantly impacted my life. In more so a personal relationship wise, family wise, everything. Um, it affects my daily schedule. It affects, even my work. How managing my symptoms with certain modalities, making sure that there's time in my schedule for that. So I would say that it has greatly impacted my life.
I just want to acknowledge one of the comments that just came in through the Q&A. Courtney had put in, it's like giving you a key to the map you've been looking at all your life. And I think that is such a great description of that. You're looking at this map, but you don't necessarily have the key that's telling you where to go or what things are there. And I do think that that's very true, that many people may describe that kind of almost like you're almost a eureka moment of when the diagnosis is achieved. I do also want to acknowledge the question that she had put in about what is the best approach to diagnosis. And she describes having a nighttime test with a following day MSLT. And is that the best or most definitive way? I would say it's the most widely used way. If you were to talk about what is technically considered the gold standard for narcolepsy type 1 or narcolepsy cataplexy, some would say that that would be using CSF testing. So doing a spinal tap and looking at the CSF orexin and hypercretin levels. However, I would say that the most widely used approach is with the PSG MSLT, recognizing limitations of that testing, and that some people who truly do have narcolepsy or even idiopathic hypersomnia for that matter may not achieve those diagnostic criteria, but that in combination with the clinical symptoms should help in resulting in those the appropriate diagnosis. And this again is where I strongly emphasize that it does take that partnership between a provider and a patient to be able to identify that. So one of the things I want to ask you, Diana, is actually two questions. Is number one, what are those most bothersome symptoms, and does it differentiate throughout the day? And then how do you optimize? How do you optimize your performance? How do you optimize your sleep routine? What are the strategies you employ?
So I would say the most bothersome symptom by far is excessive daytime sleepiness for me. And it is different for that question being, is it different for day or night? During the daytime, it is very bothersome. I do manage it as best as I can, but even with management, there are still moments where I wish I, didn't have to undergo this. And an example is like on the weekends, if I am with my son and my husband and it's nice outside, I know my 4-year-old son wants to go out and play all day. And, I know that if I don't get enough sleep the night before, if I have a lot of sleep disturbance the night before, or I don't take a nap before we plan to go outside in the afternoon, that I'm going to drag and I'm probably not going to feel as good. I'm probably not going to be as happy while I am doing that activity. And that could be very frustrating. At night, I just had this last night. I was telling my mom about it. I do have those hallucinations and sleep paralysis. Even with management, they will still come through sometimes. And when they do, they are scary. They feel so real, and it sticks with you throughout the rest of the day. Like, even though now I know that it was a dream and it was a hallucination, it's not real, it does something to you, and it just you just think about it the rest of the day and how scary it was. So as far as optimizing my sleep routine, how do I try to optimize it? One of the main things that I do is I exercise. I find that when I exercise at least 4 days a week, early in the morning, because I read that that is one of the best times of day to exercise based on cortisol levels, that actually helps my sleep routine significantly. It also helps me stay asleep more at night. I notice that I don't awaken quite so much on the days that I do work out. I try to go to bed at the same time every night during the weeknights, and then I try to wake up around the same time every day on the weekdays. On the weekends, I try to keep that routine, but weekends are supposed to be for rest and relaxation, and I take naps. I take naps during the weekend. I do have a prescription to take naps at work, but I choose to not do that. I just in my work situation, I don't know if I necessarily feel comfortable doing that. Would it help my performance? Probably, but mostly naps are on the weekends or if we're on vacation, definitely.
I'm so glad that you had brought up some of the accommodations you have at work, because Cameron has just put in the question, what workplace accommodations are provided for you or have you requested? So you did allude to the fact that you do have a prescription for napping, but what else do you request or consider?
Um, well, I haven't really with this position, working in an academic institution right now. I haven't really requested any other type of accommodations. If I did request to take that nap and give that accommodation, I know that they would provide somewhere for me to sleep. We have, as we are a medical institution, we do have a lot of exam tables, patient exam tables, and I know that one would be provided for me in my office should I need it. But I try my best to be that, that normal where, nobody else is napping at work. And so I want to try to be like that as well as best as I can. But they are very accommodating.
Yeah. And I think that's a challenge for many patients, right? They want to avoid the stigma. They already feel as though that they've inherited this disease that carries so much stigma. There's the Deuce Bigelow depiction of people just kind of falling to the ground, falling down the steps, etc. And they don't want to manifest that. They like to manifest the fact that they're normal and that there's not anything wrong with me. And I think that's incredible. And I think that that is a part of the conversation that we want to have today is how do we augment that journey, and how do we get to that, what is our normal, how do we achieve that? So I think that is really quite important. The other piece that I do just want to emphasize is that when we're talking about this shared decision making and that patient empowerment is recognizing that individuals who have a diagnosis with narcolepsy, when they're children and adolescents in primary and secondary school, they can work with the school districts under the American with Disabilities Act and Individuals with Disabilities Education Act to evaluate the child for either a 504 plan or an IEP, an individualized education plan. In addition, once you become an adult or in the college age group, you still could be afforded some of these same supports under the American with Disabilities Act. So it is important to recognize that and utilize some of those resources in order to optimize your work environment. And so it is really important. Um, the comment is, so avoiding workplace accommodations is incredible. I'm not quite certain, but I by no means, if it was taken as me stating that I think it's incredible that she's avoiding her use of resources, that wasn't my intention of how I stated that. I think it's incredible that she is so persistent in trying to achieve her normal. So if it was received the wrong way, I just want to acknowledge that. All right, so let's talk about narcolepsy. It's a complex disease, and management may require a combination of treatment, lifestyle changes, and support. Treatments can help manage some of the symptoms, but most are focused on improving excessive daytime sleepiness. And as we've already described, when you're talking about narcolepsy, it goes beyond just focusing on that excessive daytime sleepiness. And there's other factors of not only the condition, but of an individual's life that they may want to acknowledge and optimize how it's fitting in terms of their treatment. And so sometimes treatment may require multiple medications and medication adjustments to address symptom changes over time. And sometimes it's not just that the symptoms have changed, but life changes, the demands that are placed on you, other medical comorbidity, and then also just the dynamics of what your social situation may change, which then may enhance symptoms that have been there all the time, but the effect on how you're trying to achieve your normal. When you're talking about lifestyle changes, such things as scheduling naps, developing good nighttime sleep habits, and managing physical activity can also help. People with narcolepsy can adapt to these non-medicinal approaches to fit their individual experiences. The other piece I think is incredibly helpful are support groups. And we know that Wake Up Narcolepsy has incredible resources that include support groups for individuals with narcolepsy. This can be extremely beneficial to help developing coping strategies and connecting with others who may be able to offer emotional support and helpful resources. We recognize peer mentorship is an incredible resource in medicine. It's been demonstrated to be very effective, and support groups are a form of peer mentorship that really should be taken advantage of. So what's my normal? Once you're diagnosed and working with a healthcare provider, how do you know what to expect from yourself and your treatment? I very frequently encourage individuals with narcolepsy and really any chronic medical condition to really take a look and say, what do I want to achieve? What does my ideal day or night look like? What is my normal sleep schedule? And what should I expect of my daily performance? And so, like I said earlier, it's challenging because many of us may realize that when we go see our healthcare provider, the focus may be on what is the change in Epworth sleepiness scale. But I have yet to have a patient who comes to see me as a patient for a visit who comes in and says, "Hi, I'm a 17." Most typically, they're describing the level of disability that they've experienced or an adverse event that they've experienced related to either their excessive daytime sleepiness, their cataplexy, the development of severe anxiety or depression related to things that they're no longer being able to do. So it is really important to define these tangible goals that you can share with your provider in order to really characterize what a treatment plan looks like and what success is. The metrics need to go beyond the Epworth sleepiness scale or even any other validated scale for that matter, because they don't take into account the personalization of the individual in front of them. So it is important to engage your doctor to discuss your treatment priorities and make these shared decisions. It may help to communicate the quality of your nighttime sleep and your symptoms throughout the day to your doctor to understand the full impact on your life. Some of the following may aid in this discussion: notes or detailed lists of items you wish to discuss with your doctor. I'm a big fan of that, of making sure that you're not going to a doctor and go, "Oh, I wish I remembered the question that I wanted to ask." We all typically have our cell phones on ourselves. So whether you're able to put those in as verbal notes or written notes. So this way you can ensure that you're having that communication with your provider, I think is really important. Consider using a sleep or symptom diary in order to capture those data points to help your doctor understand the patterns and the impact of narcolepsy that it's having on your life. So sometimes it's nice to be able to have those recalls of this happened this one time, and I think it might have happened other times. But sometimes being able to look at all of those symptoms and the impact it's having longitudinally allows us to develop strategies beyond just increase this dose or change this medication. It may also augment the opportunity to think more strategically around those behaviors that may improve your functioning. So some of the other things I think is important for us to discuss, and I would love not only for Diana to give some feedback here, but also if anyone in the audience wants to provide some feedback. So first, Diana, what can't you do at this point because of your narcolepsy? If you were to kind of characterize those things, what would you say you can't do?
I will say one of the main things is, and it can be summarized by two words: mom guilt. It is coming home from after working all day and my son asking to play, or me wanting to cook dinner for my family, and I'm wiped. And I just want to relax on the couch, or just rest, or maybe take a 20-minute nap. And so that's one of the things that I cannot do because of my narcolepsy. I cannot come home and be present for my family the way that I want to be. That's probably the main thing right now that affects my life.
And if you were going to say that I want to define my normal, what does normal look like? And how do you measure what you want to achieve in your life?
So as far as what does my normal, or what do I think my normal should be that I should be able to go to work and have a full day of work, come home, and have the energy to cook dinner, or have the energy to do an activity with my son after work, and not be just mentally miserable. It's like literally walking through thick sand trying to get things at home done, or laundry after work. It is like literally dragging. It's so tiring. So that would be my normal, would be able to come home and have that ability to get those things done that I want to get done, and spend time with the people that I want to, without feeling so tired, and also having that brain fog. That's the other thing. What does normal look like? Despite treatment for me, my symptoms have improved, but I still experience significant, brain fog. And a normal would be for me to not have that, to have much more clarity in my thoughts.
Yeah, and I think that brings up a really important piece that we don't even commonly address in regards to when we're talking about the pent-up symptoms, is the brain fog that many patients will endorse as something that's very debilitating to them, feeling like their head is in a cloud, and it's distinct from their sleepiness. It's not that they're sleepy and they can't think clearly. It's that even I might have just taken my stimulant or my wake promoting agent and I'm feeling awake and I feel like I can do things, but my brain just does not feel like it's clearly taking in the information, or that I'm able to clearly think about those. And so, in order for you to kind of engage in that shared decision making and have these conversations with your doctor, and develop a game plan, what type of information do you think your provider needs in order to really be more helpful in illustrating these areas where you might need more help?
I think establishing a baseline. So establishing a point of, where you are right now, um, whether you're satisfied with your current normal or not, and what you gauge in your life that you want to have as a normalcy. So letting your doctor know those things, like, I want to be able to come home and I want to be able to have the energy and the brain clarity to find a recipe to make for dinner, and to play Legos with my son when I get home, whereas right now I cannot do that. Or maybe I can make dinner, but I can't get through eating dinner without needing to go to bed.
Sure.
So telling them that baseline, so that they can help see where I would like improvement.
Yeah, and I think that's important because there's no line on the Epworth that says, "Can you play Legos with your son?" Right?
Right.
And so we sometimes overlook that as a disability related to the symptoms we're experiencing, because you're able to answer all the other questions correctly, right? "Quote unquote" correctly. And
Yeah.
so I do think that becomes really important. I think further revision of how we look at a person holistically in order to really partner appropriately is important, because we can falsely reassure our providers that we're doing great because we're answering the questions right. And because during the daytime where maybe my medications are at most active, I am performing relatively well. But when it comes to the extremes of the day where there are still needs I need to accomplish, that I'm making compromises and I'm having to choose one versus the other, not both. And that is not something that is a part of the expectation of my life. It does become important. And I do think it's important that part of the reason that we quote unquote the normal is because we recognize there is no standard normal. A lot of us can sometimes think that normal is one very specific description, but that's where we do need to individualize what does normal look like for you. How do you partner with your doctor to really make shared decisions about treatment or changes to your care? What is the approaches that you find have been helpful? And then what would you like maybe see to even optimize? I think talking about some of this, that illustration, and being able to maybe integrate that, you might already be doing or thinking about doing in the future, but what does that currently look like?
So in regards to partnering with my doctor, if I am on a current, let's say, medication regimen or specific sleep schedule, and that was maybe working for me at one point, and now I'm noticing that I'm not responding to it as well, or something has changed, I reach out to my doctor right away, even if I'm not, um, even if I don't have an appointment scheduled in the near future, and I let them know exactly what I'm feeling, and how I was when that changed for me, and how it's affecting my life. So I definitely keep my physician in the loop. But like, hey, I can't function even on the weekends. I'm in bed half of the day because I'm so tired, and this is the most important time for me to be with my family. And so they are very responsive to that. And so using that as a baseline, now my physician knows that that is important to me. And so if I don't even bring that up initially, that's a question that's asked. Well, how is it going at home? How is your relationship going? how's your son doing? Are you able to play? And so that's something that, and that really makes you feel more personalized, I think, when you have a physician that is that in tuned to how you want your normal to be. Yeah.
And I think that makes all the difference in the world. I don't think any of us as a patient ever want to feel as though we're just identified as a disease.
Absolutely.
And I think that's why I love the fact that when I see a lot of these different slides, that it always is saying PWN, person with narcolepsy. I cringe when people say the narcoleptic individual, because that is not the individual identification, right? And so I think the fact that your provider goes beyond to really identify you as who you are by even the context of your family, your work environment, et cetera, I think really is where we need to, in medicine, to personalize the experience. So I think that's incredible. I think there's a couple of questions that have come in. And so Mary Beth asked about skiing, downhill, not cross country, and whether that's safe for someone with type 1 narcolepsy. First, of course, I'm going to say that it's something I really do think that you need to discuss specifically with your provider. But I would say that some of the guiding principles that I would use in regards to a conversation of something like downhill skiing would be, how well is the excessive daytime sleepiness and cataplexy controlled? And your concern about being on a chairlift, I agree, especially if it's an individual who, with the excitement of being on a chairlift, getting anticipation to go down the slopes, that they get so excited that they go into a cataplexy. I do share your concern. So it really would be personalized again to having that conversation, and I think the overall comfort of what does the control of the symptoms look like, and is there someone who's able to keep her protected in the first couple of trials, et cetera. So I would make that recommendation. There's another one that came in from Ruby, who's asking Diana, what are you comfortable with discussing what treatment you're currently taking at the moment, or is that something you would defer?
So I can say that I am on both. I'm on a daytime medication, and as far as disclosing names, I probably won't disclose names, but I do take pharmacotherapy as well as lifestyle changes, like I had mentioned before. So.
Wonderful. There was another question that has come in that asks from Becky, that asked about how frequently is narcolepsy misdiagnosed as chronic fatigue syndrome, and basically describing that there's been sleep problems since childhood and was diagnosed with chronic fatigue syndrome at 22, and then just really couldn't recover energies. She didn't have a sleep study until her 40s, and was diagnosed with severe restless leg syndrome, where periodic limb movement disorders are extremely common in individuals with narcolepsy. And then she had another sleep study with the MSLT in November 2021, where restless leg wasn't mentioned, but the MSLT indicated narcolepsy. And so not specific to chronic fatigue, but misdiagnosis is extremely common. If you look at the journey of many individuals with narcolepsy, they may see 3 to 5 specialty providers before meeting the provider that gives them the appropriate diagnosis. And along that journey, they may also achieve 3 to 5 different diagnoses that may or may not be relevant, because some patients with narcolepsy do have true medical or psychiatric comorbidity. But many times they may be misdirecting or misguiding the patient's journey away from the diagnosis of narcolepsy, such as you've illustrated with your case.
Wonderful. I think that you were just putting your different, go ahead.
Yeah, no, and these are just some helpful resources for individuals with narcolepsy. Please visit narcolepsydiscovery.com and sign up to receive a sleep and symptom diary. Again, as we've illustrated, this can be critical to facilitating effective communication between you and your provider. But other incredible resources, of course, Wake Up Narcolepsy is one that has to be at the top there, because it does have invaluable resources. But then there are also some of these other resources that may be informative for you.